Good afternoon all. My topic is vessel density and nerve fiber layer thickness in mild to moderate primary open angle glaucoma. Coming to the introduction, glaucoma is a leading cause of irreversible blindness. So early diagnosis and close monitoring of glaucoma are important. Mechanical theory explains most of the cases but not all cases. So vascular theory came, which suggests impaired ocular blood flow results in periods of intermittent ischemia resulting in optic nerve damage. OCT angiography is a newer, non-invasive dye-less technique that visualizes retinal and choroidal microvasculature using the dynamic motion of RBCs. Also, radial peripapillary capillary network are specific plexus of capillary bed within the RNFL layer around the optic disc, which is vulnerable to glaucomatous damage, and it constitutes a critical blood source to satisfy nutritional demands of RGC axons. Superficial plexus vessel densities shows better diagnostic accuracy for glaucoma than deep plexus density. Aim of the study was to assess the relationship between peripapillary vessel density, perfusion density as measured by octa and RNFL thickness in patients with mild to moderate primary open angle glaucoma. To examine the strength of correlation between RNFL loss and reduction in vascular density and to determine which quadrant exhibited the strongest correlation with each other. Materials and method. It was an observational cross-sectional study conducted between April 2024 to April 2025. Participants included a total of 50 patients of mild to moderate glaucoma. Visual field mean deviation of less than -6 decibel and between -6 decibel to -12 decibel were taken as mild to moderate glaucoma based on Hoda-Parrish-Anderson criteria by HFA single field analysis. Inclusion criteria include age more than 18 years, open angle on gonioscopic examination, best corrected visual acuity of 612 or better. Exclusion criteria include media opacities that prevented good quality octa images, age less than 18 years or more than 90 years, previous diagnosis of optic nerve and retinal vascular pathology, high myopia, non-glaucomatous optic neuropathy, all forms of secondary open angle glaucoma, and octa images with a signal strength of less than 7. Coming to the methodology, basic demographic details and ophthalmologic investigation, including best corrected visual acuity, IOP, axial length, and visual field were recorded. Spectral domain OCT images were obtained from Cyrus ST OCT. RNFL thickness are measured using the 200 x 200 optic disc cube scanning protocol. Octa was performed simultaneously using the same device running the Angioplex software. Vessel density and perfusion density were automatically measured. Outcome measures. Octa results for the optic nerve head measured vessel density and perfusion density of full, outer, inner disc and quadrant by superior, inferior, nasal and temporal vessel and perfusion density. RNFL thickness measurements for the peripapillary zone were recorded in superior, inferior, nasal and temporal quadrants. Coming to the results, most of them were within the age group of 61 to 70 years and 60% of them were females and 40% were males. And this is a table showing the correlation between RNFL thickness and vessel density. Here we can see that the average RNFL thickness showed moderate positive correlation with the full and inner vessel density, and among the quadrants, superior and inferior RNFL thickness showed moderate positive correlation with the full and inner vessel density. And this is the table showing relation between RNFL thickness and perfusion density. Here also average RNFL thickness show significant correlation with perfusion density, especially full and inner, and superior and inferior quadrants also show significant correlation with the perfusion density. And this is the heat map figure showing the correlation between quadrant RNFL and vessel density. Here we can see that the superior RNFL thickness showed the most significant correlation with the corresponding superior vessel density. Inferior RNFL and nasal RNFL are also significant, but superior was the most significant. And this is a heat map figure showing the relation between quadrant RNFL and perfusion density. Here also we can see that the superior RNFL and superior perfusion density were most correlated. Coming to the discussion, the study showed a strong topographic link between RNFL thinning, that is structural loss, and reduced peripapillary capillary density, supporting the role of vascular factors in glaucoma, which was similar to study by Bill et al. And inner ring vessel density and perfusion density showed the strongest correlation, indicating microvasculature near the optic nerve head closely reflects the axonal health. Also, superior RNFL thickness exhibited the strongest correlation observed in the entire quadrant specific analysis, and superior and inferior regions, which are the most vulnerable to glaucomatous structural damage, are also where the relationship between structural loss and vascular compromise is most apparent. The temporal quadrant, normally the thinnest, remains relatively preserved. So coming to conclusion, in mild to moderate primary open-angle glaucoma, there is a significant topographically specific correlation between RNFL thinning and reduced peripapillary microvasculature. All these findings support the hypothesis that vascular compromise is intrinsically linked to neurodegeneration in glaucoma and highlight the diagnostic value of coordinate-specific octa analysis. These are my references.
Doctor, that is, we have got slides, PowerPoint slides preparations also have got 25 marks. From here and I am not able to see the slides properly and all the letters are very small. So now, that's why slide preparation also you must make it in such a way it should be attractive.
Yes.
Okay, so that you can score more marks.
Okay.
You understood?
Okay, sir.
Okay, thank you.
Mm. 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 Mild to moderate. Mm. 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 Okay, sir.
Practically, how can we make a difference in our clinical care?
We can, since a significant amount of RNFL loss can occur before the appearance of visual field changes and clinical changes, we can use octa as a part of routine investigation.
Are we too expensive?
Mm.
Really, if it is really mandatory, like identifying the correct clinical cases where this will make a difference. Those are the patients you should subject them to OCTA. But practically getting it done on everybody with no visual field effects, nothing, we need to think about.
Thank you.
Thank you, Dr.